Good afternoon, everybody. Welcome to the afternoon session. Today we have very common hand problems, and there can be a lot of difficulties. And for those uncommon problems, we have got an expert panel of speakers, and for that we have conveners Dr. Lad and Dr. Kamble. I hand over the mic to them for the further proceedings.
Thank you very much, sir. Without wasting time, I would like to invite Dr. Praveen Bharadwaj to share his first case. Dr. Praveen Bharadwaj is a senior hand surgeon at Ganga Hospital, Coimbatore.
Okay, thank you very much, Parag. We all know that trigger finger release is one of the most satisfying operation, not only for the patient, but even for the doctors. Because within 5 minutes, the same amount what we have for the talk, the patient would be relieved of his problem and would be totally comfortable. But story is not always like that, because sometimes there may be snakes in the grass, as the topic says, and this is one of the most striking example for that. So this patient, we can see there is a long horizontal scar across all the 4 fingers, and this patient has undergone a trigger finger release for all the fingers. And this is the same patient who still has a kind of triggering. You see, when she is extending the finger, suddenly one pop-up comes. So this patient was diagnosed to have trigger finger and done trigger finger release for all the fingers. But if we examine carefully on the dorsal aspect, you see there is a snake there. So it is not a trigger finger. In fact, it is a dislocation of the extensor tendons, which was causing that type of clucking type of sound, which was appearing like a trigger. And somebody has misdiagnosed it and done trigger finger release, which of course will not going to work. So important point to learn here is that whenever there is a classical trigger finger, the triggering is at the PIP joint, like this. But if we see the first video, here the PIP joint becomes straight and the cluck comes when the MCP joint is extending. So whenever we see that it is not the PIP joint which is causing the cluck, that means there could be some different problem. So there is a snake therein. The second, which could be again be a very irritating problem, is your finished release of the A1 pulley, but still the trigger does not get relieved. The patient is still not able to extend the finger. So this is quite an uncommon problem, the incidence being 2 to 5 in 100 patients. But it is again a snake because your whole program of that day is disturbed if such thing happens. So it has been very nicely summarized by Dr. Al-Katan in a nice paper in JHS European in 2007. And he says that there are 4 types of these triggers which do not get relieved by releasing the A1 pulley. The type 1 is where there is an enlarged flexor tendon at the A3 pulley area. So this is common in patients who have been doing a lot of bowling because of the direct pressure over the A3 pulley. And the treatment is just release of the A3 pulley, and it can be diagnosed by localized tenderness at the MPX area, and it gives good result by releasing of the A3 pulley. The type 2 is where there is enlargement of the flexor tendon in throughout the A2 pulley region. So whenever the whole A2 pulley area flexor tendon is enlarged, you need to do a reduction of the size of the FDP tendon as described by Dr. Kleinert. And later on, people have found that resecting one slip of the FDS is much simpler. The type 3 is where the flexor tendon is enlarged throughout the area of A2 and A4 pulley. So in such cases, again, the resection of one slip of FDS would do the trick. And this was one case, we had a patient, he was a surgeon himself, who had the pulley release done, but after that the trigger persisted, and secondarily the patient was operated, one FDS slip was removed. And the last type is where there is enlargement of the flexor tendon in the A1 pulley and some part of the A2 pulley. And these are the patients which are the commonest of all these 4, and they require release of some part of the A2 pulley as well. As in this patient, we required to release 1/3 of the A2 pulley also, and after that was done, the patient was quite okay and movements were complete. So to summarize, the trigger finger release, in fact, is a simple and satisfying operation. But we need to be careful about these snakes by carefully examining the patient and make sure that triggering is only at the PIP joint. And be aware of this digital trigger which may trouble someday. Thank you very much.
Thank you, Dr. Praveen. Are there any questions from the audience? Dr. Praveen, do you consider by seeing this, do you consider ultrasonography prior to any trigger finger release?
Yeah. So we would not do ultrasound for each and every case. But if on examination or by history wise there is anything atypical, then we should do. Like a patient suddenly developing trigger without any previous pain, or a patient having this type of trigger which is not the PIP joint, it is at DIP joint or MCP joint, or any patient who has more swelling in the area of the flexor tendon. So anything atypical, do the ultrasound, otherwise every case it is not required.
And you have done all these snakes, I mean the different cases that you have shown. Did your post-op protocol change after doing that?
Post-op protocol does not change. Even if we are reducing the FDP or removing one slip of the FDS, the patient has to immediately move. Yeah. No change in the post-op.
Thank you so much. Any questions from the faculty? Thank you so much, Dr. Praveen.
Thank you, Parag.
I now request Dr. Patankar to give his next talk on reason of restricted flexion in proximal phalanx fractures.
Yeah, in many cases of fractures of the proximal phalanx, especially the proximal third, we find that the patient is not able to actively flex the finger. The first thing we must remember that the proximal phalanx is very, very closely related to the flexor sheath and in turn the flexor tendons, both the tendons, and also of the extensor, but fortunately the extensor is not bound down in any sheath. So this example, you see, there's a hardly fracture is hardly you can make out on the middle finger, and this patient was unable to flex the finger. Now the cause of the restricted flexion in these cases is, in this case there must have been bleeding and the patient was not mobilized, and that's why the tendons got stuck up at the fracture site or in the sheath. It's another case where the fracture is malunited, and here also you can see that the patient is not able to actively flex. Now here there is a disproportion in the sheath, or you can see there is a narrowing of the sheath. You can see in this way, and that's why the flexor tendon gets stuck. The third example, which is also very common, is that the concavity of the proximal phalanx, the volar concavity is lost. You can see the sharp spike in this that pokes on the flexor tendon and causes the tendon or injury inside. And you can see this picture in which that the flexor tendons get narrowed and stuck up at the level of the fracture site. In addition to that, of course, there is bleeding. So in all the cases of fracture of the proximal phalanx, anatomical reduction, I would say, is not essential, but definitely desirable. If you can get anatomical reduction, nothing like it. So even minor errors like this in fixation can lead to major disability. You can see the sharp spike here, and that caused the restriction of the flexion. And this patient responded very well to a release of both the flexor tendons. At the same time, when you are doing this procedure, you can see for a sharp bone spike. If necessary, you can just clean off the bone from there. And then, obviously, all these patients will require a splint after the wound healing, and that gives a very good result. This case presented with stiffness of all the three fingers. You can see various fracture patterns in the middle ring and little finger, and patient was unable to bend the finger at all actively. So this patient also needed this flexor tenolysis. Both the tendons have to be opened up. The A2 pulley you have to reach the A2 pulley with this blunt instrument and just clean off the passage, and then the patient will get even in early post-op phase, you can see a good flexion here. This patient presented with a malunion, and this patient also was having a absolute no flexion in the finger. So this patient required a surgery for the myelinion also. So the first stage of the surgery was to release the flexor tendons from the volar aspect. The sharp bone spike was, the bone was osteotomized at this level and the fracture was loosened. The tendons were mobilized like this, the sublimis and the profundus. The wound was sutured and then the fracture was fixed with K-wires, a screw and a bone graft. And you can see in this case that the volar concavity of the proximal phalanx was restored, due to which the flexor tendons get a smooth surface to glide and then you will not get the problem. This was the near normal function recovered in this patient. So the important thing to restore the flexion after fracture of the proximal phalanx is to restore the volar concavity, to get a stable fixation and to achieve early active flexion, for which the fixation must be stable and painless, like this. So your volar concavity must be restored. That's very important. See the lateral view, try to see the lateral views on the X-ray and see that the volar concavity is restored. In these cases, you will be rewarded with a very good active flexion of the patient. Now this patient, so what do we do? So this patient is a case of a closed displaced fracture of the base of the middle phalanx, of the proximal phalanx. This is treated with closed reduction and traction in flexion. You keep this for about 2 weeks, let the patient become painless, and then you start with active extension and flexion after 2 weeks. And even if the fracture is slightly myelinated, as in this case, the fracture heals, but there is no sharp spike here. You have already mobilized this patient during the healing phase, and patient will get a very good range of motion, as like this. This was a case of multiple displaced fractures of the proximal phalanx. This was treated with a closed reduction and external fixator. What you see in this case is the restoration of the volar concavity of the proximal phalanx, and that is the fixator. That's the fracture which went on to heal very well in spite of the fixator, and that's the function. That's the pre-op X-ray on the side. This was a case of a closed fractures of all the proximal phalangeal base. Now here, all these fractures were treated with closed K wiring. The advantage of this is that we restored the volar concavity. We ensured that the flexor tendons start moving. That is the early range of motion. About 2 weeks later, patient started. Afterwards, the patient keeps the finger back in traction in the splint. And this was the patient who has got active flexion, but his extension is restricted because of the K wires. So that is the K wire which was removed, and he regained active flexion extension. This fellow is a milkman. He delivers milk every day in the morning. And this is the last case of a displaced closed intra-articular fracture of the proximal phalanx in a neurologist. You can see the loss of active flexion here. This was treated with a plate and a bone graft. And the advantage of this is that we have restored the volar concavity. The gliding edge of the flexor tendons is smooth, and this is the result at 3 weeks post-op. No physiotherapy has been taken yet. So to avoid snakes in the grass for the proximal phalangeal fractures, you must restore the volar concavity, you must achieve stable fixation, and you must ensure that patient gets an early active flexion. I thank you all for your attention.
Thank you, sir. Any question to Dr. Patankar?
Hemant?
Yeah.
One comment, because very often patients are immobilized excessively. Sometimes I have seen for 6 weeks, 8 weeks they are in plaster, and they'll end up with more complications.
Yes.
So, apart from the volar concavity, the mobilization that you have started at 2 weeks is a very important factor.
Yeah, that's why if the patient becomes painless, if the fixation is stable, then you can really mobilize and prevent that flexor tendon adhesions, which is impending in every patient of a proximal phalangeal fracture. So that we should avoid, and just see that the flexor tendon don't get stuck up, not only to the bone, but even amongst themselves. That also causes restriction of flexion.
Thank you, sir.
Thank you so much.
May I request the next speaker, Dr. Amit Varade, for his next talk about the DeQuervain's release. Is it simple? And how to avoid complication.
Very good afternoon. I thank organizers of WIROC for giving this opportunity. I'll be presenting on DeQuervain stenosynovitis. This is a very common surgery and we all do it routinely. But we have to find out the snake in the grass. And here I have two snakes in the grass. So case 1, this young lady presented with pain on radial side of the thumb on doing movements of the thumb. And she was operated for DeQuervain's release before 1 month. And then they presented to me and her pain was not going. She was not able to do her activities of daily life. And this is the video on doing movements of the thumb, on doing Finkelson test. She was having severe pain. So now we have to find out the snake. So, what is the problem? Is it an inadequate release or it is a recurrence? So, the snake, these are the intro of, this is the intro of video. APL and EPB tendon was very well released by previous surgeon. But what was missing is, this is the snake. See, there is an extra compartment and slip of EPB tendon, which was not released in the previous surgery. So, we have released that. So, we have to be very, very careful and we should think about this. This was immediate post-op. It was done under wide awake anesthesia. So the question is how to identify this EPB slip pre-operatively. Pre-operatively, we have to do one test which is called, in that test, we have to do hyperextension at the MCP joint of the thumb and abduction against resistance. If there is pain on hyperextension against resistance of MCP joint, then there are approximately 70% chances that there may be an extra slip of the EPB tendon. And this study was done by our friend Dr. Praveen Bharadwaj and team at Ganga Hospital. And it was a previous, it was previously also quoted by Professor Alexander. So this is test. When we suspect this, then do sonography. Then sonography will, good sonologist will pick up this thing. Another point I want to highlight here, in such cases, do not give steroid to the patient, directly advise him surgery. So this was the snake. So another case, another snake we have to find out in DeQuervain's. This young, old 61-year-old lady, she presented, see this is the video, she presented with severe pain on radial side of left wrist joint. And she was also operated for DeQuervain's release before 5 months. We have explored it and she was having neuroma of the superficial radial nerve. We have to be very careful about this snake here, and the snake here is superficial radial nerve. In anatomy we can very well see the close relationship of superficial radial nerve with APL and EPB tendon, and there only we have to release. So the care, whenever we do this surgery, just cut the skin subcutaneously and then spread with sharp scissor tip or artery forceps, and find out first superficial radial nerve, keep it aside, retract it nicely, and then release the first extensor compartment sheath. So then we excised the neuroma and buried the nerve in the muscle. It was not possible to repair the nerve end to end because that distal part was not traceable. And she got nice pain relief, her pre-op and post-op video. And now she has gone back to work and she's doing her activities of daily living routinely. So these are the two take-home messages. Avoid injury to superficial radial nerve and keep in mind about the extra compartment and EPB slips. Thank you very much.
Thank you, Dr. Amit. Any questions from the audience? Okay. So with this, I would like to invite colleague Dr. Prashant Kamble to present his case, which is showing any tricky complication.
Good afternoon, all. So here is one case I would like to show. Is the fracture or the implant responsible for extension lost after metacarpal head fracture fixation? So it is a patient who is a 30-year male IT engineer by profession, had an injury and fractured metacarpal neck. And the typical way to treat this fracture is passing the intramedullary K wires, which was done here. And at approximately 2.5 months, this post-op X-ray, everything looks fine. But suddenly one day he called and he said there is loss of extension at my finger. So this was his video. Looks nice. Finger extension is there. But now look at the second video. If he flexes all the MCP joint, he is barely able to do the extension at little finger. So this finger is dropped and it's almost now 10 weeks since the surgery. So we did a non-invasive investigation, local ultrasound, which was confirmed there is a rupture of extensor digiti minimi and almost 7 centimeter gap with the proximal fragment at the level of extensor retinaculum and distal fragmented migrated at the shaft of the metacarpal. So we revisited the X-ray. We saw what is the snake here. So if you see the in oblique view metacarpal base, it's somewhere in the green dots, and the K wires which was fixed for the metacarpal neck fixation was almost a couple of centimeters away from the bone, which was protruding and which was damaging the extensor tendon. So explored surgery and intraoperative, we found the sac was empty, and you can see there is a K wire which was immediately just below the extensor digiti minimi tendon, and the retracted ends were retrieved, and we did the primary grafting from the ED extensor indices. So this was his pre-op range of motion where the loss of extension, and almost 2 months post second surgery where the, after the graft, tendon graft, this was the result, post-op complete extension of the little finger. So the take home, or the very important point, don't damage that at first instant. Have the proper entry point. Remember the entry point for the fifth metacarpal is a dorso-ulnar. Rest other metacarpal base, it's on the dorsal, on the more on the ulnar side, except for the index finger, the middle finger, it is on the radial side. Make an entry point under vision. Just don't poke the skin and enter, or make an entry point. Take a skin knife, open a little bit, under vision, you make an entry point and pass your K wires without damaging the extensor tendon and the CMC joint as well. The very important is completely bury the K wire once the fixation is done. On, forget about the removal, or if you want to remove, keep them outside of the skin. Don't just keep them below the skin, and instruct the patient about the cleaning and dressing of the K wire. Spin track should not be infected. So we use K wire day to day life, every day when we take the patient. Be aware of those K wire. Just don't poke the skin and damage the extensor tendons, or for that matter any tendons or the digital nerve in hand and wrist. See, proper visualize, see them, and under vision pass all those wire. So avoid, don't let that snake bite your extensor tendon. Be careful while passing those K wires. Thank you.
Thank you, Dr. Prashant. Any questions from the audience? Dr. Prashant, is there, to avoid that injury, is there any method or way that you would like to use apart from bouquet technique to fix that boxer's fracture?
Certainly, if the angulation is less, you can treat them conservatively by close reduction. In a compliant patient, you just do the traction and ask this reduction technique maneuver where you can flex the tip of the finger and you can reduce that. And once that is, you can splint, or you can give the ulnar gutter slab or splint, and patient should be compliant to check the post with the plaster there should not be loss of reduction.
Okay. Thank you. Sir, any questions? Dr. Warrior, sir, and Dr. Yes. Good afternoon, everybody. Carpal tunnel syndrome, I think we certainly do this operation very commonly. I am presenting a case in a 55-year-old maid lady, housewife, and she had undergone left side carpal tunnel release. It was done, and then she was absolutely asymptomatic. And right side also carpal tunnel release was done. And 5 months post right side carpal tunnel release, she had no improvement in symptoms in terms of numbness and abductor pollicis brevis weakness. So, I mean, opposition deficit. So, this was in the right hand, the similar symptoms of carpal tunnel like nocturnal symptoms and strong tinel sign at the scar and into the distal forearm. The phalanx test was positive and no improvement in sensation, and there was wasting of thenar muscle. So this is the 5 months post-operative status of that carpal tunnel, right side. And so based on these findings, we decided to re-explore the carpal tunnel, and we wanted to find out what exactly could be the reason. So the ultrasonography just showed post-operative changes of a median nerve decompression. There was some fibrosis. They diagnosed as a thickened median nerve. Usually, unless in carpal tunnel is a chronic compression disease. So usually we see either the nerve is ischemic or smaller in caliber. They mentioned as a thick median nerve. And like a post carpal tunnel release status, I am sorry the spelling mistake of a POT, and they said the carpal tunnel is significantly wide open, so there was no inadequate compression on the sonography report, and they found significant flexor tenosynovitis. So I thought the diagnosis could be the flexor tenosynovitis, which was probably not removed, and that's why she had recurrence of symptom, and that's why we considered exploration. But we decided to explore because to find out whether the decompression was inadequate and whether the flexor tenosynovitis was the cause of compression. And while doing so, initially also when she had undergone a right side carpal tunnel release, the symptoms were since 4-5 months. So now the status is 8 to 10 months post surgery. So I wanted to do opponentsplasty in the same sitting. And this was on exploration. We could find out a thickened hypertrophic tenosynovial tissue. Most of the time we do see this, but if the grip strength of the patient is normal as compared to other side, and if there is no significant pain, then we don't usually recommend to do flexor tenosynovectomy. But this patient had flexor tenosynovitis. But apart from this, this was not the snake in our grass. The real snake was she had bifid median nerve. So there were 2 median nerve, and that the median there, that was initially the right side carpal tunnel decompression was done by mini open technique, and that's why they could release one nerve. But the another nerve was inadequately, or it was not decompressed at all. So the message here that if persistence of symptoms post carpal tunnel release, beware of possibility of median nerve. I thought that this is a rare case for me, but in the literature there are classifications of bifid median nerve. So it's a known entity. Please keep in mind, apart from a flexor tenosynovial hypertrophic tissue, keep in mind that this could be one of the reason of persistence of symptom even after surgery. And then after our opponentsplasty and adequate decompression, her symptoms started reducing next month, and then she recovered properly. So the 2 important causes are inadequate release and flexor tenosynovial tissue hypertrophy, but beware of median nerve as well, bifid median nerve. Thank you so much.
Any question to Dr. Parag?
MRI would have helped you before exploring for the second time.
Yeah, it would have helped, sir. But again, some kind of fibrosis apart from that MRI would not have confirmed. I feel dynamic sonography from a trained person could have diagnosed 2 median nerves. That would have been possibility.
Dr. Parag, did you do histopathology of the flexor?
Yes, sir. It was just a chronic synovitis, non-specific chronic synovitis. It was not a rheumatoid or any metabolic disease. We have done that. We had done that, sir.
Just a comment.
Yes, sir.
It was probably the extensive tenosynoectomy or rather extensive release, because whether there is one branch or 2 branches, so far as you release the whole carpal tunnel, it should have recovered. So bifid is probably not the reason.
Okay. So this message also could have been taken that when we do a mini open carpal tunnel release, that we make sure that from the mini open incision also you can actually see and release the carpal tunnel till the distal forearm fascia. Then you probably would not have missed, the 2 nerves. Thank you.
Where it starts, hello? Yes, sir. Where it starts bifurcating? At what point it starts bifurcating?
So this was the only one case which I had in my experience. It started bifurcating at around 8 centimeter proximal to the wrist crease, sir. And in the literature, what is the classification that has been mentioned? They have mentioned level from distal forearm fascia to the proximal wrist crease, distal wrist crease, and at the level of thenar motor branch. These are the 4 classifications where the median nerve was bifurcated. Yeah.
All right. Thank you, Dr. Parag.
Thank you.
May I now request next speaker, Dr. Bipin, to talk about the cause of increased pain post volar ganglion surgery. Over to Dr. Bipin.
Thank you. So volar ganglion is the most common surgery any one plastic surgeon or an orthopedic surgeon performs. So, but you have to find some points here and important steps which you can miss. Like many snakes have been discussed before. There is a snake in this as well. So you can see this excellent sonography done by my colleague Dr. Ankit, and he is showing everything here. FPL, the ganglion is arising from the FPL, and it is encasing the flexor carpi radialis tendon. A note here that he is mentioning that it is encasing the flexor carpi radialis tendon. I'll come back to it later. And this was operated by an orthopedic surgeon with a routine ganglion surgery, as we always do. So post-op, the patient had immense pain and the pain didn't subside. She was given a plaster. And post 1 month, she was referred to a pain physician who called me to look at the patient. So as a hand surgeon, I thought I will have a look. And so she came with this type of symptoms, like there were tremors and severe pain in the hand. We were unable to diagnose the cause. Tenal sign was, there was a lot of tenal sign along the nerve, and especially in the scar, she was unable, she really used to wince with pain here on the scar. So I need to find it. I really wanted to diagnose this problem, but how to convince the patient, because she was already taken by the pain physician for some stellate ganglion block. I said, let's diagnose the problem first. So the quest for diagnosis began. So on clinical examination, severe pain, suspected CRPS by the pain physician, and was posted for stellate ganglion block. There was allodynia. EMG and CV was done, yes, it was normal, but there was sensory loss along the thinner eminence. Again, I spoke to the primary surgeon and also the sonologist, both good friends of mine. And the sonologist say कि cutaneous branch atak gaya lag raha hai. Okay, thank you. So I found out that, but how to convince the patient that this small branch will cause a problem. So this is the snake here, the palmar cutaneous branch. So we most of us know there is a branch there, but we usually miss it. So what I did was I gave a xylocaine injection block. This technique has been described in 1980s, but we miss out on the, as time passes. So as the xylocaine block was given, the patient started writing immediately and pain subsided completely. The parents and the girl was very happy, and they said, now you do whatever you want. So convincing the patient is important. So they were, now the thing of stellate ganglion block is out. The pain physician referred the patient to me, you take over. So this is actually CRPS2 that we diagnose the cause and treat it. So what we did was the release of the palmar cutaneous branch. And you can see the palmar cutaneous branch goes and it supplies the thinner eminence and it arises 4 centimeter proximal to the wrist crease. Post 1 month release, she had good movement. However, that is not the end. She was unable to write, right-handed girl, unable to write. She's a software engineer, means doing a software engineering. So she was still unable to write here. Now that is more again important. Now we had to do something again. Again, I called up my sonologist friend and he suggested that it is again entrapped. Now what to do? Now we were stuck. Now what to do? Release to kar diya hai. Movement to aa raha hai. Now what to do? So again, there is a question mark in front of us. So I came across this article and Dr. Amit Varade has also said, and this is the final thing, what I decided. But as you know, we have to explain the patient there is always a sensory loss on the thinner and the area where the median nerve palmar cutaneous branch supplies. Patient was okay with it because the pain she was suffering was immense. So what we did is we buried the nerve inside the pronator quadratus, drilled the hole inside the bone, the radius, and put the nerve inside so that it will never come out. So this is 1 month post-op and 1.5 years after post-first surgery. Maybe I should have done this before, but some training in microsurgery always wants us to save the nerves. But finally she started writing and writing well, and she's writing 2 pages now. She has some symptoms intermittently, but I suppose they will settle. So what do you look for? So in distal and radius approach, so the learning point here is that do not go on the ulnar side of the FCR sheath, go on the radial side. It has been described in AO, but no one tells us that the approach should be on the radial side and between the radial artery and the FCR. Again, now in the release of carpal tunnel, you have to be away and ulnar to the thinner crease, that is at least 2 to 3 mm away from the thinner crease. Thank you.
Thank you, Dr. Bipin. Any questions from the audience? Yeah.
Parag had presented a case that I had given him a few years ago at WIROC. It is a common complication of closure of the volar plate, lower end radius plating. And I had treated 2 of these cases by nerve grafting the median nerve, that palmar cutaneous branch, with complete relief of pain. So when we are dealing with a iatrogenic neuroma of the palmar cutaneous branch, the distal portion can be readily found and can do a short nerve graft with complete relief of pain. That burying it in a different place will still cause that deafferentation pain signals coming to the brain. So it is not an panacea for neuromata.
Yes.
So the way to treat neuromata is to reconstruct the nerve.
So the scarring was along the nerve, sir. The sonologist had told me.
You can always find the terminal portion very close to the thinner eminence and do a nerve graft.
Maybe. Yeah. Thank you, sir, for that opinion. Yeah.
May I ask Dr. Bhatia, sir, the choice of nerve graft would be in this case a sural nerve or something from the hand?
No, I prefer to take the calcaneal branch of the sural nerve. It is the perfect size for the palmar cutaneous branch of the median nerve.
Thank you, sir, for another tip. Great. Yeah. Thank you.
So, yeah, Dr. Prashant Sound, sir. Yeah.
Yes, sir.
Bipin, I want to ask, what is the natural history of the ganglion? Do all ganglions require surgery?
Sir, this ganglion was arising from the FP. I have not done this surgery. Yeah. So it most of them arises from the joint. So it arises from the joint, but in this case it was arising from the FPL, as per the sonologist. So I don't know that how it. But there was a big. So that is what I wanted to tell you, that he had written before that it was encasing the FCR sheet. So I called him and told him, now you start writing that it is near the palmar cutaneous branch also. So that such things, like all the branches, 3 branches, radial cutaneous, what Amit showed, then the palmar cutaneous, and the third and the most dangerous branch is the ulnar cutaneous branch. That is the worrisome branch. This is, I didn't know that this was also a major problem, but this caused a lot of problem in this. Thank you.
I've taken your suggestion, but there is an issue. I have taken or heard your suggestion, but there is an issue in cases of distal and radius with significant edema and say carpal tunnel syndrome type of a picture with acute fracture radius. You want to plate the distal radius. You want to extend and release the nerve in the carpal tunnel. So whereas in the radius or in the forearm, you want to go on the radial side of the flexor carpi radialis. Whereas in the distal part, you want to go towards the ulnar side of the median nerve. So at what point, and have you ever seen these branches and prisms?
I always see the palmar cutaneous branches in such scenario. In fact, when we do the volar lunate fragment, which requires a central approach, you need to see this nerve and the branch. That is what is my protocol. Yeah.
Thank you so much, Dr. Bipin.
Bipin will move on.
Now we will have last speaker, last ball 4 runs, Dr. Warrior, to show about his challenges in hand surgery.
Thank you. It always seems nice to put wires in. When you're putting them in, it seems very simple without making any incisions. Here's one such that I did, and immediately the patient came with symptoms that were quite annoying. So when the affliction is dense, an early exploration is easy and should be done before fibrosis sets in. And that's exactly what I did. And in this case, I had called up Anil and I had taken the help of Mangal Parihar as well, because this was a very difficult condition for me. As soon as I pulled out the wire, I found that the nerve was unaffected. It was just being pinched, and I was lucky that the patient recovered. And we've seen these 2 branches in an earlier presentation as well. So we need to identify the faulty implant and address it expediently. Prevention certainly is better than cure, and therefore, when you're putting in your wires, you need to be aware of these nerves and take care. Here's a young man who was operated 4 years before
Excuse
he
me,
presented.
sir. Just a minute. The screen is not visible. Just a minute, sir.
Sometimes it's visible here, sometimes it's not. Anand, special treatment for me. Okay. So here's a young man who came to me 4 years after he was operated, after a plate removal was done. This is the pure definition of plate removal. The screws were left in. This may be because of substandard material used for the screws, and his problem was he's one of our residents working with us, and every time he was working, I could almost hear the crepitus of his extensors, and you can see why that was happening. Now, these are all screws pointing on the dorsal side. Hollow milling these screws would make for a very weak and susceptible radius. So I had to come up with something else. So I went on from the dorsal side just to grind off the prominent screw tips. And there was the screw tip that was right under the muscles, causing the problem. So what I did was I hollow milled only the near cortex and then used a broken screw extractor for the prominent screws, pulled them out. So a small hole for the hollow mill to get a grabbing force on the screw, and that's how I could pull it out, and left only half of the radius affected and the other half was strong enough. I just called him a week ago and told him to send me an X-ray, and this is his X-ray. He's a prolific orthopedic surgeon with absolutely no complaints at this time. This was another young man whose misfortune was that he fell down and had a fracture after this distal radius, the shaft fracture. And the surgeon tried to remove his own plate and couldn't. So he left the other fracture as it is, put in a couple of wires because he had cracked this plate while trying to remove it. So violence in this place is very, very difficult to, is very, very improper because it causes more problems than otherwise. When you go in for such cases, you've got to prepare for war. And you've got to prepare for a non-violent war because you need to have implements that are going to help you out to remove these implants. And I just ground off all the screw heads and removed the plate. So you need to be very, very aware of this. And this is the last case where we had this 17-year-old young gymnast, a young girl, and at the national level with a locked plate fixation, which wasn't looking too good, but would definitely go on to unite. There's no question about the fact that she's going to unite. But she had a problem. The plate was very prominent because of the screws pulling out, and that was right where the extensor digitorum communis crosses this plate. A CT scan showed that the fracture union was in progress. So the plan was to remove the implant, realign and refix, then do a bone grafting. Quite clearly, this implant had to come out. So I went in and started removing. All the proximal screws were removed very safely, and suddenly the last two screws wouldn't come out. I used the screwdriver and it just kept on turning inside. So I cut off the plate. There was nothing else I could do because if I brought in those instruments which I showed you in the earlier where I prepared for war, there would be a problem. And I started referring to the implant removal set, operates, and I found that there's just one instrument for these 1.5 and 2 millimeter screws that are put, the locking screws, so they don't have a system for that. So I did this post-surgery, but at that time I was completely lost. I didn't know what to do. So instead I cut the plate as flush as I could, and I filed it off, put in bone grafts, and came out. And not only that, I saw to it that I could get a good layer of soft tissues because this plate, the extensor tendon is still going to be rubbing on that plate, so I could cover it up like so. And that's her 5 weeks post-op. So that's the third snake, that is tread with care when removing new implants. Check whether the company has a manual on this. Always have plan B, C, D, E, F, innumerable plans, but know when to stop. Don't do more harm. I couldn't use those huge instruments to try and hollow mill or break or ablate that plate. Thank you very much, and I invite you for much more of such discussions to the 5th Indo-US Hand Surgery Conference in Manipal on 18th and 19th March 2023. Thank you.
Thank you, Warrior sir, for a wonderful presentation.
I thank the conveners and the speakers. Wonderful case distribute, as in the plethora of the cases with notable complications.